previous lessons in the last week, we passed over the cardiomyopathies in adult patients. Today, we'd like to talk about the cardiomyopathies in children. There are 6 parts in my presentation. For the first one, I would like to overview the cardiomyopathy in children. The first one, I will remind a little bit about the definition of the cardiomyopathy. The cardiomyopathy is the disease of the heart muscle and not associated with other forms of the heart disease, such as congenital heart disease, valvular heart disease, and coronary artery disease. The cardiomyopathies in children is much rarer than the adult patients, but once diagnosed, it carries a substantial risk of morbidity and mortality, and is the primary indication for heart transplantation during childhood. We can see this table from the guidelines of ESC of the cardiomyopathy in 2023. It's clearly that the prevalence of the cardiomyopathies in children is much rarer than the adult patient. We can see there are 5 phenotypes of cardiomyopathies in children. It includes hypertrophic cardiomyopathy, dilated cardiomyopathy, non-dilated left ventricle, and the arrhythmogenic and restrictive. In my presentation, I just talk about 3 most common of cardiomyopathies in children is HCM, DCM, and RCM. I think this slide is the most important slide in my presentation. We can see the center, the circle is pediatric cardiomyopathies. It's divided into 6 branches, and the thicker of the branch, the more common of the phenotypes is. We can see that here, the 2 most common phenotypes in cardiomyopathies in children is HCM and DCM, with the DCM is the most common, and the four one is the restrictive cardiomyopathy, arrhythmogenic, non-compaction, and the mixed type. We look for the branch of DCM. The DCM, the main cause of DCM is secondary cause, such as inflammatory, toxin-induced or metabolic syndrome, and the primary is much rarer than the secondary cause. In contrast, in the hypertrophic cardiomyopathy, the primary is the main cause of the HCM in children. We see this picture. Here is the normal heart, the dilated cardiomyopathy, the heart muscle stretched and weakens, and it usually starts in the left ventricle. In the hypertrophic cardiomyopathy, the heart muscle is thickened, the restrictive. The wall of the ventricle becomes stiff and is induced the dilated of two atriums. And the last one is the arrhythmogenic right ventricular cardiomyopathy. Fat and scar tissue replace muscle in the right ventricle. This is the clinical approach for diagnosis the cardiomyopathy in children. It includes four important parts. The first part is the inheritance pattern with the genetic testing. The second part is the ECG. The third one is echocardiogram, and the last one is systemic phenotype. We can see the circle here. It includes 5 circles. For the echocardiogram, we divide it into the phenotypes of the left ventricle in the echocardiogram. It includes concentric, eccentric, and global hypokinesia, and pulmonary stenosis and congenital heart disease. It may manifested by the hypertrophic cardiomyopathy or the RCM. And the systemic phenotype we can see here. We can see that the rasopathy is appear many times in this algorithm, And the restopathy is the disorders of the channels of proliferation of the membrane. It controls the development of the cell membranes. And the syndrome that we see on the clinical situation is the Noonan syndrome. Here is the typical phase of the Noonan syndrome babies. It's characterized by the large head compared to face, or maybe the wide spaced eyes here. And it affects the heart. It can manifest by the hypertrophic cardiomyopathy or pulmonary valve stenosis here. The most common of HCM cause maybe the GSD type 2 is glycogen storage disease type 2, or we call the palm disease. It is there are 5 types of GSD here, but the only in type 2 affects on the heart. So the enzyme of replacement has been shown to result in the reversal of the left ventricular hypertrophy. So we must exclude the palm disease in infants with the HCM. These are the images of HCM in the baby with the palm disease. And the genetic testing plays an important role in the diagnosing of cardiomyopathy in children. You see this algorithm, the patients in the center of this approach. Before the genetic testing, we have to consider about the advantage and the drawbacks of the genetic testing. And when we decide to make the genetic testing, it's divided into 2 pathways. The one is decline cascade genetic testing, and we just continue to clinical screening and accept the risk of developing disease. In the pathway of we can make the genetic testing. It's divided into genotype positive and genotype negative. This table in the guidelines show the genes. The genes affect related to the phenotypes of the cardiomyopathies. We can see here with the circle when it's blue, it's definitive or strong evidence. The light blue is moderate evidence. The white is no association, and the gray one is generally rare. And the number of the cycle is very important. If three circles is very important, 2 is common and 1 is less common. So I come to the first phenotypes of the cardiomyopathies in children. It's dilated cardiomyopathy. It's the most common form of CMP in children, characterized by dilated LV and systolic dysfunction. The etiology of DCM often idiopathic and maybe due to the infection. The two virus is may meet in the clinical situation is echovirus or Coxsackie virus. It may be caused by familial DCM and secondary cause. The clinical presentation of DCM is maybe symptomatic heart failure with syncope, dyspnea, or volume overload, and some patients are symptomatic. In the physical examination, we can see the variable degrees of cardiac enlargement or the triangular venous pressure raised, and the MR, the mitral regurgitation, and the tricuspid regurgitation may occur. For the diagnostic testing, the chest X-ray may manifest by cardiomegaly. The ECG may non-specific change with sinus tachycardia, AFib, or ventricular tachycardia, and with the atrial abnormalities. The echocardiography is the most important tools for diagnosis of the dilated cardiomyopathies. In difference with the adult patients, the criteria for diagnose the DCM in children based on the Z-score. We can see we can use the parameters of LVIDD, the left ventricular interdimension in diastolic, and LVEDV. LVESV is increased and Z-score more than +2, and the LVE and the LV of left ventricular ejection fraction is reduced with a Z-score less than -2. This slide is the summary of the criteria for diagnosis of DCM. It includes the LVEF and the volume of the left ventricle. The cardiac MRI may be the most helpful tool in the diagnosis of the DCM. It's the accurate assessment of the left ventricular ejection fraction, the LV cavity size, and the wall thickness. Localized in the cardiac MRIs can localize the tissue injury. It includes edema, hyperemia, and fibrosis. The disadvantage in use cardiac MRI for children is need to use the gandothelium in young children. For the treatment, the therapeutic strategy includes the preload and afterload reduction therapy. We can use the beta blocker if there are not contraindications, and the cardiac transplant is the treatment of choice of DCM. In the children, the treatment of DCM is mainly the treatment of the heart failure with reduced EF, but the evidence of the drugs used in the children does not exist as the adult patient. The next one is the hypertrophic myocardiopathy. The definition is hypertrophy and non-dilated ventricle in the absence of the hemodynamic causes, and they're usually familiar with autosomal dominant inheritance, but maybe occur sporadically, and the most common cause of sudden death in young athletes. The septal hypertrophy may cause of the dynamic LV outflow obstruction, and the SAM, the systolic anterior motion of the mitral valve, can cause the mitral regurgitation. For the clinical presentation, the patient may be asymptomatic or have some non-specific symptoms like dyspnea, fatigue, or syncope. The physical examination may show the double impulse apex or palpable LV hill, or we can hear the mid-systolic murmur and the parasystolic murmur of the MR. The chest X-ray may show the cardiomegaly in the electrocardiogram. The ECG in infants and with HCM is universally abnormal, but changes are non-specific. We can usually see the prolonged QT interval in this patient. The echocardiography is very important in diagnosis of HCM with the specific score. The wall thickness measurements based on the Z-score. We can use the Z-score equivalent to the adult wall thickness. The normal wall thickness in the adult is 8 plus and minus 2 millimeters. And the interesting one here, we have also already know the criteria for diagnosis of HCM with the wall thickness is more than 15. It's equivalent of Z-score +6 and +7 in children, and with the wall thickness is 13 and 14 millimeters in a patient with the family history of HCM, the Z-score equivalent of +4 and +6. This table summarizes the diagnosis of HCM. The treatment is maybe use beta blocker or rate-limiting calcium antagonist, and no pharmacological treatment is known to improve the prognosis in HCM and the ICD for patients with the high risk of SCD. And the last one, I would like to talk about the RCM, and it's the very rare condition in children, and it may be idiopathic, but can be associated with systemic disease. The main physiology is ventricle filling is impaired because ventricles are stiff, and it leads to high atrial pressure with the atrial hypertrophy, dilatation, and later AFib. And the diagnosis of RCM is very difficult and require complex Doppler echocardiography and the CT and MRI, or maybe endomyocardial biopsy may be done. And this table summarizes the criteria for diagnosis of RCM. The treatment just symptomatic, and the prognosis of RCM is poor, and the transplantation is the best treatment of the RCM. On this slide is the take-home messages. After my presentation, I think the majority of the doctors in this room is not the expert in the pediatric cardiology. So I think the message that I would like to send to you is early recognition and diagnosis of cardiomyopathies in children, and transfer the patients to the expert such as Mr. Thủy. After that, I show two typical cases of the cardiomyopathy in children. The patient one is 2 months old girl, was admitted due to low breastfeeding and dry cough without fever. For personal medical history, she was diagnosed of dilated cardiomyopathy with the left ventricular ejection fraction of 40% with the genotype positive 2-chain mutation here. On the 23rd day of life, she was a child 2 on 2 with C-section and full term. Her birth weight is 3,200 grams with normal pregnancy. Her mother did not have gestational diabetes. For the family history was unremarkable. The final diagnosis is dilated cardiomyopathy with genotype positive with heart failure, reduced the ejection fraction, and the ostium secundum ASD here, and bronchitis. Firstly, we can see the chest X-ray here with the cardiomegaly with the chest thoracic ratio more than 0.5 with clear lung field. The ECG shows sinus tachycardia with the heart rate about 170 beats per minute and normal axis, and have the voltage criteria for LV enlargement. The negative T wave appears in many leads, and it's a counterclockwise rotation. Here is some image of echo. In the left, we can see the parasternal long axis view, and in the right one is the parasternal short axis view. We can see the severely dilated of the left ventricle with the severely reduced of the systolic function, and diffusely hypokinetic of the world motion. This is the ostium secundum atrial septal defect, and the size of the ASD is about 5 millimeters with the left to right shunt. Here is respectively the apical 4-chamber view, the apical 2-chamber view, and the apical 3-chamber view, with the severely reduced the systolic function and very dilated of the left ventricle. We can see the mild to moderate MR and mild to moderate TR. This is the O2 EF measured by the GE machine with the EF just 12%, and this is the longitudinal global strain. It's just about minus 4.8%.
Dr. Ngọc Anh, what about the difference in diagnosis of this case? How to differentiate with other cause? You cannot say idiopathic immediately. You understand, Dr. Ngọc Anh? Because we cannot say, because this case, Dr. Khoa show the gene reason. But if we see this case without the gene reason, how we need to have, how can we have difference in diagnosis of this case? Thì thầy hỏi con là bây giờ mình nhìn một đứa nhỏ mấy tháng tuổi, nó bị bệnh cơ tim giãn nở, nếu mình chưa có cái kết quả di truyền thì mình phải nghĩ có thể có nguyên nhân khác mà chữa được. Những nguyên nhân nào mình cần nghĩ đến một đứa nhỏ như thế này. Tại nếu mình nói này là bệnh cơ tim di truyền thì vấn đề nó khác. Mình cần loại những cái gì để mình chẩn đoán?
Dạ thưa thầy, là nghĩ tới viêm cơ tim.
Viêm cơ tim. Ok, viêm cơ tim gì nữa?
Con mới nghĩ được.
Khoa chưa đây. Give me, show me the diagnosis, definition of dilated cardiomyopathy. The slide of this. In the diagnosis of dilated cardiomyopathy, we need to eliminate another cause. The person may have hypertension. The person may have congenital heart disease. The person may have coronary heart disease. The person may have this cause. It can be make dilated idiopathic dilated cardiomyopathy. I have one case in the 1994 in Vietnam at that time. A young children about 1 year old come to the hospital. At that time, somebody think the person very related cardiomyopathy sent by some doctor from Children One Hospital. We have dilated up 4 chamber. But when I do echo of this case, I notice one thing: the very thickness of the septum and also thickness of the wall of the left ventricle. At that time, I asked my young doctor to measure the blood pressure of the children. When we measure the blood pressure of the children, very high blood pressure of the brachial, but very low blood pressure of the ankle. What do you think about this case? If we have a very high blood pressure of brachial and very low blood pressure ankle, which cause?
Hẹp eo động mạch chủ.
Coarctation. And I do echo in the suprasternal echo. I see severe coarctation. And after surgery, 6 months later, the heart returned nearly normal. And so when you see a patient with dilated cardiomyopathy, when you think the cause is idiopathic or familial, we need to find some causes we can treat it before we give. We said that you can do nothing for the patient. That's for dilated cardiomyopathy. Okay, thank you, Dr. Ngọc Anh. And you, what's your name?
Yeah, my name is Tươi.
Okay, Dr. Tươi. When we need to do genotype of the children with cardiomyopathy, do we need to do genotype every patient? when we have a patient who dilated hypertrophic cardiomyopathy,
Yeah.
who diagnosed dilated cardiomyopathy, who diagnosed resistance, do we need to do genotype every patient, all of the patient? Okay, Dr. Khoa, can you answer this?
I think the prevalence of the cardiomyopathies in children is very rare. So I think that we do not make the genetic testing for all of the patients.
You think this? Okay, Dr. Nhung, what do you think? Con tên là gì con? Trang, okay, what do you think? Sorry.
Yeah, I see one that reported in ECS 2021. They said that all of the patients with have DCM or HCM need to do genetic testing, and also on the first degree elder relatives of these patients need to do that.
Okay, thank you, Dr. Cha. I agree with Cha. Every case, we need to do genotype, genetic testing. If we found out this person have a gene for dilated cardiomyopathy, what will we do, Cha?
Clinical evaluation, MRI, I'm sorry, echo associated 5 years or more for this patient.
No, I would like to ask you, if you find out gene, one kind of gene in this patient, we need to check we do genotype. We need to check gene of the brother and sister of the patient, or with the father or the mother of the patient.
We need to do the first degree.
First degree,
Yeah.
and the first degree before. And the young baby, he have no children. And we don't know the third, we know. But for the other, we do three things. Some relative first,
Yeah.
and brother and friend, sister,
Yeah.
father and mother,
Yeah,
and the
father and
child
child.
of the patient. But
Yeah.
for the children, we need to do 2 generations of the
Yeah.
patient. I think that we apply this also for the other. When you see a cardiomyopathy, we need to check gene. In the future, every case, we need to check gene. We cannot say it's a very rare disease. We need to do it. Because if the gene positive, we need to check another person in the family. We explain to patient, we need to do this because it will affect the family, the first, second, third degree generation of the patient. Okay, any question from the audience? Dr. Thủy, have you seen, con là Thủy vào? Have you seen hypertrophic cardiomyopathy in children?
No, I haven't seen in my.
No.
Can you repeat the question?
Have you ever seen a hypertrophic cardiomyopathy in children?
Sorry, I haven't seen any case before.
Before.
Yes.
And for adult, have you ever seen?
In our center, I have seen many cases
Of adult hypertrophic cardiomyopathy.
Yes.
Okay, thank you, Dr. Thủy.
Good afternoon, teacher. Good afternoon, Dr. Thui, and all of my colleagues in the Cardiovascular Center. Today, I would like to continue my presentation about the topic of cardiomyopathy in children. With the last case, this is a typical case of hypertrophic myocardiopathy in children. The patient is a 4-year-old boy, was admitted for further investigations after a period without treatment of HCM. For the personal medical history, he was diagnosed of non-obstructed HCM at 4 months old. He was the child of 1 with normal delivery, with a preterm birth, 31 weeks and 5 days, with a birth weight about 1,500 grams. The family history was unremarkable, and the final diagnosis is the non-obstructed HCM. This is the electrocardiogram of this patient. We can see that the EKG show a sinus tachycardia with the heart rate about 100 beats per minute and normal axis. And there is a voltage criteria for left ventricular enlargement for so-called Lion criteria, and with the T wave flat and negative in D3 and from the V4 to V6. We can see the echo for the view. This is the parasternal long axis view. We can see the very thick of the wall thickness, the wall every wall with the mild to moderate AR. We come to the parasternal short axis view. We can see the very thick of elbow wall and the hypertrophy of the papillary muscle. This is the end mode with the ejection fraction of the left ventricle is about 60%. These are the 4 chamber, the 2 chamber and 3 chambers view respectively. We can see the systolic function of left ventricle is quite good, and with the very thick wall of the left ventricle. Middle strain and the global strain is reduced. I finished my presentation, and we turn to the discussion of this topic.
Good afternoon, all of my colleagues. I think that after the 2 cases of the interesting cardiomyopathy in children of Dr. Khoa presentation, I hope that you can make some questions and put some questions for Dr. Khoa, because the 2 cases he present here is also got the diagnosis before, and also the echocardiography report. It just focus on the diagnosis and function. But in the approach, especially when you do in the echo room, especially you do in the down many times, and sometimes you got the case from the neonate department or the pediatric department refer to our echo room, and how step by step you make the diagnosis when you do the first time, but without diagnosis. So I hope that you can help our college understand how step by step and what thing you first do and need to do when you see a case that you're thinking of maybe the cardiomyopathy.
I have some slides to summarize my topic. This is the pediatric clinical approach, CMP clinical approach. The first step, the most important one, is recognize the signs and symptoms of heart failure in infants and young children. The sign and symptom of heart failure in children is non-specific, and we can see this syndrome can mimic all the same signs and symptoms of another organs like the lungs or the digestive system. The second step, the EKG and echocardiography, is the 2 basic tests for CMP screening in children. These are the echo and the ECG. The step 2. The step 3, when the cardiomyopathy was suspected, the CMRI is important for both etiologic and prognosis of the cardiomyopathy. Step 4, we have to we have to search about the causes of the pediatric cardiomyopathy. We can see here the cause of cardiomyopathy is divided into the secondary and primary causes, and we must to confirm or exclude all the secondary cause before you confirm the cause is idiopathic. You can see here the idiopathic is the most common cause in both dilated cardiomyopathy and hypertrophic cardiomyopathy. Some important causes we might have to find or to exclude is neuromuscular, metabolic cause, the mitochondrial cause, or syndromic cause. With this test here, and we see that the genetic testing is very important and should be made for all children with their first degree relatives. These are the protocol of approach in the Children's Hospital of Chicago for the BCM in children with the test here. You can see the imaging tests and blood tests and some of the enzyme for metabolic syndrome. And this algorithm is for diagnosis of HCM in children with you can see the 5 colors: physical examination, the inheritance pattern, the metabolic lab screening, the echocardiography, and electrocardiography. And for the treatment, the management of the pediatric CMP is divided into 2 pathways. The first pathway is manage the causes of the cardiomyopathy, and the second pathway is the manage of the heart failure. This algorithm is for the management of the heart failure in children. It's may a little bit different from the adult patients. Yes, I finished my presentation.
Something misunderstand from me and Dr. Khoa. I hope that in the echo room you can make the diagnosis step by step, have the other doctor can understand and can approach in the practice. And firstly, Dr. Khoa make the different diagnosis with the cardiomyopathy. For example, 2 kinds of the cardiomyopathy common in the pediatric patient is dilated and also the hypertrophy. Maybe the ratio is quite different to the adult, so make the diagnosis is very important. The Z-score in the pediatric patient is also the noted, because everywhere you make the measure in the pediatric patient, you need to compare, because 3 mm in the adult is quite normal, but in the small baby is thickened or maybe enlargement of the LV volume. I don't think the doctor here or the adult doctor need to understand how to treatment and the other when making clinical examination. Maybe it's from the pediatric cardiologist view. So about the diagnosis and management for that. But with the doctors who working in our center, I hope that you can make a view from that. Yeah, I just focused on something Dr. Khoa maybe not mentioned in his presentation. Firstly, about the echo, about the history examination, something we don't mention, but here is 2 kinds of the pediatric cardiomyopathy. Recently, you see is dilated and hypertrophy cardiomyopathy, and others is a definition of the cardiomyopathy. You need to remember, we need to exclude some other diagnosis before we confirm that the patient with the cardiomyopathy. And also about the genetic, it's very important. It's the key in the making diagnosis in the pediatric cardiomyopathy and the risk of the family member.
Why I said that? Because you can see on the schematic there, if a pediatric patient coming to us, we make the genetic testing and the patient with the mutation, for example. Firstly, we think that is a idiopathic cardiomyopathy, dilated cardiomyopathy, for example. But after that, when you taking the test for the first line of the family, maybe the father, the mother, or the other members in their family got the same genes like that. At that time, it's changed from the idiopathic with the new onset variant to the family dilated cardiomyopathy. It may be make change, and also with the change in the diagnosis, the changing in the prognosis for the patient. And the other thing, Dr. Khoa mentioned many things, is a step by step with the same in the adult cardiomyopathy. If you check X-ray, ECG, and especially in the echocardiography, and I mentioned to you that need to remember that you need to compare with the Z-score, compare with the key weight and also the age of the patient. Maybe Dr. Khoa will introduce to some page for comparing the Z-score for of the college here. And why I need to mention about that many times, because some patient with the misdiagnosis, before this patient, my patient, is also making diagnosis that the hypertrophic cardiomyopathy. But when you go back, you can see the LVOT is no obstruction, and also the thicken of all of the left heart. But when you check up, we can see find out here, this patient also got the coarctation, severe coarctation, and also the bicuspid aortic valve in the same case. And with this case, we change the diagnosis, we change the prognosis, and also the future of this baby is better. I mentioned that because you know that the pediatric patient is not the small adult. Again and again, many times I saw that. So in the treatment, Dr. Khoa show you many things, but some very good medication we can apply for the adult, but we cannot use for the children, especially the group that are under 1 year old. Seem have no any medication like the ACE inhibitor or ARP inhibitor. Just two things we can use. I hope that some doctor can give the questions for Dr. Khoa and me. I would like to listen to the adult doctor can put the questions in the pediatric topic like this, because about the congenital heart disease, many kinds of the congenital heart disease got the dilated LV, for example, left to right congenital heart disease, we need to include first. And with the severe LVOT obstruction or the coarctation, also we have got the thicken of the wall of the LV, and the others maybe the same, and it will make the misdiagnosis. 1 week ago, I remember that Dr. Mai Hong did the echocardiography, and she concluded that in the 3 days old baby with the dilated LV, rarely, because we saw that in the physical, when the baby is newborn, the RV is always balanced a little bit larger than the LV. And that case is very interesting. I also presented last week when discussion, because that patient has got the large PDA, huge PDA, and it's got the left to right so big. So that patient got the enlargement of the LV really soon. So something is not common. We need to review. And one cause of the LV enlargement that I mentioned, and also maybe we forget to mention it last time, is a coronary artery, congenital coronary artery disease. That means ANCA or ACABA. It will make the supply coronary flow different, and it will make the enlargement of the LV.
For children, so when we do the MRI MRI for the
Yeah.
children, do we have any difficulties or do we need any cautions or mention when we
Yeah.
do MRI for them?
Yeah, we got, but I think in Vietnam, I saw the youngest patient do the MRI, cardiac MRI is more than 1 years old, because small, the fast heart rate and cooperation of the patient is very difficult, and the time that we need to do the cardiac MRI is longer than the MSCT. So we just exclude something. And also the myocarditis is also one of the important cause of the dilated cardiomyopathy. So with the age from the 4 to maybe teenager always, when we make the diagnosis, especially the cause, finding the cause, we need to do the cardiac MRI. So how about opinion, Dr. Phúc?
One more thing is because when the patient have the infant, so we need to intubate the child for keep the patient calm down. And so in the foreigner, they have the ventilation with the MRI compatible for intubated the patient. Because if we only intubated the patient, we packing, we suction for patient is not enough to control the ventilation for patient. So that's why, and the time for MRI is very long, but the price of the ventilation machine is very high, of the MRI compatible for the children. So that is a reason until now, as I know, is maybe children want they're planning for buy the MRI compatible with the ECMO with the ventilation. So now it's not available. So they only do the a little bit child speaker. So here we have Dr. Chang just joined our team about the pediatric cardiologist. So what do you think about the, are there any thing you share about the experience for you for this kind of condition in the children to hospital?
In my experience, every baby have diagnosis with CMP. We also take a lot of tests for them, such as echocardiography, ECG, and we just need to exclude the congenital heart disease like ANCAPA, like coarctation. Yeah, that's just all.
I think it's own of the opinion is own of you and Dr. Khoa tell already. One more thing I highlight a little bit about the hypertrophy of the cardiomyopathy is in the children, one of the difference with the adults is we can have the right ventricle hypertrophy. Also, it's not only in the left side, it's involved about the right side also. And that is very difficult for Noonan syndrome for the pediatric patient. So, and that is make very difficult. And one more thing is about the alcohol ablation is not available for children when we compare with adults. So because the risk factor of the surgical is also very high, in Vietnam, we don't do too much about the surgical for cut down of the hypertrophy for patient. But for the children, we don't have the alcohol ablation. And how about you share about the experience about the treatment for patient with the dilated myocardiopathy?
Children with diagnosis of dilated cardiomyopathy, we just nowadays we after have diagnosis, we always do the genetic testing for them, and in some of the case we find some mutation of like lack of carnitine, and after we use carnitine for this baby, the LVD is more good, and the heart is become better.
Do you have any experience about the sacubitril valsartan in the treatment of the heart failure for patient?
No.
Okay, so because that is very popular in adults, but in the children, so Dr. Thủy can share, because you have some few cases you using the Overio for treatment in the children.
And that kind of the medication is very important, and it's got the significant improvement in the adult. But in the pediatric patient, it's just apply for the group more than 12 months. So far, FDA is just approved for that group, and the other is off-label. Okay, but it's significant. Like I can describe a baby like the first day he coming to our hospital. His father make to bring him from the to the department, to the room, and everywhere. But when we use the medication for that patient, I remember that diuretic and also the sacubitril valsartan, 1 week later, when he can discharge, he can bring his Swiss K and around our colon to the elevator. And it's impressed me a lot about the indication for that kind of patient, especially in the dilated cardiomyopathy. And recently, the Panorama HF study is very famous, and we hope that in next some years we can apply that kind of medication for one of our pediatric population. About the medication, why I said that is very different in the adult, because you can see if we have 4 groups of the medication we can apply for treatment the heart failure in the adult. Very ACE inhibitor, ARB, or the beta blocker. One kind we call is the perospirone we have got in Vietnam, and the other is the sacubitril valsartan in the compile, and in the adult, the beta blocker and also the ACE inhibitor or ARB. Not all of the medication can apply for the baby, because you know that we can use the medication for the pediatric patient when we got the research, and all of the research is run from the adult research. So some kinds of the ACE inhibitor is enalapril or the captopril. Recently, we rarely see we use that for treatment the heart failure, especially we have got the other new one. But in the pediatric patient, we still use that, especially in the Nhi Đồng hospital. They also use the captopril 2 to 3 days, 3 times a day. Although we have got the many research about the enalapril, it's better than. And the ARB, we have got medicine, losartan, Diovan, for example, but apply for the pediatric population. Recently, we just use the valsartan, and also adding some sacubitril for the group more than 1 year old. And the other is beta blocker. Not all of the beta blocker can use. The cavelirone is very popular, and the others is bisoprolol. But with the group less than 6 months old, never use. Although we need to control the heart rhythm in that kind of patient, heart failure. But more than 6 months, we can use the procoralan. That means ivabradine for the patient to control if the high heart rhythm, the high heart rate. And I think it's quite a little bit different compared with Nhi Đồng 2, where Dr. Trang working, because we have got the case, the first case last time, the patient treatment there, and after that the patient referred to our hospital for continue, and also changing between the captopril and enalapril and the other medication when the patient coming there and coming here. Many times it's make the confused from the parents. So after that, me and Dr. Lợi made the discussion that we try to use just one kind of the medication, have the baby stable in dose.
So normally it's in the capital pill, they give at least 3 to 4 times per day. But in daily practice in the children's hospital, normally it's using 2 times a day because it's for easy for give for patient. But for pharmacologists, is I think 2 times per day is not enough for capital pill. So that is a reason we changed to the enalapril in practice in our hospital. And the other question is I want to ask you is how your experience about the SGLT2 in the heart failure of children?
It's not indicated for the kind of the pediatric patient. I hope that in next some years, because it's the efficiency is very good.
In the children, we don't have any trial about that one. But so I see in the literature, I see some case report apply for SGLT2 in the adult congenital heart disease. So for single ventricle or something. So I think it's we need to waiting more. And so look like it's the patient in right heart failure. Also, we don't have any start already. Sometimes we try to using for we have the effect or not. Yeah, thank you.
Is there any questions? And Dr. Khoa, how about your comment about this topic?
Thank you, Dr. Thủy. When I create this slide, I feel very interesting about the pediatric cardiomyopathies because many differences between the adult patient and the pediatric patients. I think it's a very interesting topic, and thank you because you helped me to understand more about the pediatric cardiomyopathy.